One
This
of you please
conference
respond.
will now be recorded.
Okay.
Yes, ma'am.
Uh, yeah, okay. Today we'll discuss about postpartum hemorrhage. This is the most important topic for you. You have asked for some topics, right? These will, along with those, this topic will also be discussed in this month. So coming to the definition of postpartum hemorrhage, it is defined quantitatively and qualitatively. Coming to the quantitative definition, blood loss more or equal to 500 ml in the vaginal delivery, or more or equal to 1000 ml in cesarean section, or any fall in hemoglobin concentration, that is 10% fall compared to the pre-labor values. This is defined as a hemorrhage. And coming to the incidence of this postpartum hemorrhage, it is 1 in 22 and 1 in 20 in sections and 1 in 100 in deliveries. And coming to the qualitative definition, it is any amount of bleeding from or into the genital tract, and this should be followed after the birth of the baby up to the end of the puerperium. And this should adversely affect the general condition of the patient, and this should be evidenced by rise in the pulse and fall in blood pressure. So there should be tachycardia or hypertension, and hypertension should be present to come to a diagnosis of postpartum hemorrhage. And the next will be etiology. This PPH, it is categorized into primary or secondary. The primary is early PPH, and secondary will be the late PPH. That is the primary PPH. When there is excessive bleeding that occurs within 24 hours of delivery, it is a primary PPH. And if it is from 24 hours up to 12 weeks, then we'll call it as a secondary PPH. Coming to the causes of PPH, that is early, it may be most common cause will be the uterine atony. This is seen in almost 75% of cases, and the other causes will be the laceration, I mean trauma to the lower genital tract or upper genital tract, or any lower urinary tract lacerations, or next will be the tissue, that is retained products of conception, or invasive presentation like placenta increta, and placenta percreta, and thromboplastin disorders like any von Willebrand disease or any other diseases will cause PPH. So this is in generally classified into tone, tissue, trauma, and then thromboplastin causes. Tone, that is uterine atony, trauma to any lacerations or injuries to the lower genital tract or upper genital tract, and tissue, it may be due to retained placental products or any other products, and thromboplastin disorders will classify along with these 4 T's. And coming to the late causes, it can be either due to the infection in the genital tract or any retained products of conception, or placental site subinvolution will also lead to PPH, and any coagulopathies. So coming to the uterine atony, it is defined as the inability of the uterine myometrium to contract effectively, and it is the most common cause of primary PPH. It is generally seen in 75% to 80% of cases, and any factor which prevents a proper contraction and retraction of the uterus may predispose to atonicity. So coming to the risk factors for this uterine atony, it may be either due to over-distension, that is in multiple gestation, polyhydramnios, fetal macrosomia. In all these conditions, there may be over-distension of the uterus, so that there will be more stretching of the uterine muscles, which leads to loss of its tone, and which leads to atony. And in grand multipara, as there will be pendulous abdomen, and because of multiple pregnancies, there will be, uh, previous number of deliveries, there will be laxity in the tone of the muscles. So it also leads to uterine atony. And conditions like antepartum hemorrhage, like abruption and placenta previa, initiation and augmentation of labor conditions, and anesthesia, if we are using anesthesia, then it may lead to atony. Mismanaged third stage of labor, rapid or prolonged labor, precipitate labor, uterine infection, inversions, any retained products of conception, abnormal placenta, anesthetic drugs like isoflurane, enflurane, nitroglycerin, and malnutrition and anemia. This plays a major role because, as we all know, anemia, it leads to the most common complication will be PPH, and uterine fibroids also leads to PPH. Clinical manifestations, depending upon the patient's general condition and amount of the blood loss, will classify it into mild, moderate, and severe PPH. And occasionally, the external bleeding may be slightly less, but the uterus may become distended with blood and clots. And coming to the general signs, they may manifest, they may have restlessness due to severe loss of blood, and they have faintness, sweating, air hunger, and increased pulse rate will be seen, and hypotension will be there. And as there is increased loss of blood, they may land up in anemia, so pallor may also be seen. And patient will be anxious, and she complains of thirst, as there will be more loss of she'll land up in hypovolemic shock, so she'll complain of thirst. And in extreme cases, syncope or death may also be seen. And on examination, we'll see a shallow respiration, and on parabdominal examination, the uterus will be flabby, as there is no a tone, and it will, as there is loss of tone, the uterus will be enlarged, and it is almost up to umbilicus in some conditions. And coming to the diagnosis, we have to go with a bimanual palpation of the uterus, and we have to confirm the diagnosis. And in such cases, instances, we have to differentiate from atonic PPH and dramatic form. In atonic PPH, the uterus will be large and flabby above the umbilicus, and in dramatic form, the uterus is contracted and firm below the umbilicus, and there will be some laceration seen in the genital tract in traumatic form. And this is all about signs, symptoms, and diagnosis. And coming to the prevention, in antenatal period only, if she's having any anemia, malnutrition, we have to correct her anemic status, and then nutrition supply should be adequately provided to the mother, and we have to improve the health status of the mother. High risk patients should be screened priorly, and they should be delivered in a well equipped hospital. Blood grouping and typing should be done, as we may require blood transfusion. So prior to the surgery only, we have to go with the blood grouping and typing. And before delivering the patient, we have to localize the placenta by either ultrasound or MRI. And coming to the intranatal prevention, atonic hemorrhage can be prevented by careful monitoring, and risk factor assessment in the antenatal period should be done. And this can be done by active management of the third stage of labor, and spontaneous placental separation during cesarean delivery should be done, and prolonged postpartum oxytocin infusion. These are the main 3 steps to prevent the atonic hemorrhage in the intranatal period. So coming to the active management of the third stage of labor, we have to administer oxytocin as soon as possible, as soon as the baby is delivered. And if skilled birth attendant is available, then we have to do a controlled contraction. And if it is not available, then we should not go for a controlled contraction. And we have to give a sustained uterine massage if um, we have to do. And then uterine tone assessment for identification of early atony should be done. And coming to the management, in prophylaxis should be given, that is good antenatal and intranatal care, as we already discussed. And in antenatal period, we have to give a general nutrition of the patient should be improved, and anemia should be treated. And all pregnant women must have their blood grouping and typing, as we already discussed. And in multiparas, those with hydramnios and multiple pregnancy or APH, all these patients should be anticipated PPH priorly only, and should give 10 units of oxytocin intravenously for 4 to 8 hours after the delivery of the baby. And coming to the curative treatment, first, the main objective of this treatment is to provide the lost blood. We have to replace the lost blood, and then we have to stop the bleeding. These two should be done simultaneously. So first, immediate measures. If we suspect any PPH, then what immediate measures we have to do means, first call for extra help. We have to ask some other assistant to come, and then we have to put 2 large bore 14 gauge intravenous cannulas, and can then keep the patient flat and warm, and send blood for investigations like full blood count, group, cross matching, and diagnostic tests like RFT and LFT should be done. And coagulation screening should be done, including fibrinogen, and ask for 2 units of blood immediately. And in the meanwhile, infuse the patient with 2 liters of normal saline or any plasma substitutes like hemacil, gelatin, so that the vascular bed will re-expand. Then after this, after giving her fluids, then not after, simultaneously these all should be done. Then we have to give her oxygen by mask, that is 10 to 15 liters per minute should be given. And we have to immediately start 20 units of oxytocin, 1 liter of normal saline at the rate of 60 drops per minute. And then we have to arrange for blood. Transfuse blood as soon as possible, and Foley's catheterization to be done, so that we have to monitor the urine output, so we can assess whether the patient is recovering or whether she is having a hypovolemic shock or not. And after this, We have to monitor her pulse rate, blood pressure, temperature, respiratory rate, and oximetry should be done, and urine output should be monitored. So after these preliminary steps, the next method to prevent the PPH means we have to go with a bimanual uterine massage. The uterus should be compressed between the external and internal, externally by placing a hand over the fundus, and internally intravaginal hand should be placed in the anterior fornix of the vagina, and we have to compress the uterus between or both hands. And care must be taken to avoid any aggressive massage that can injure large vessels in the broad ligament. And this bimanual compression is a very successful life-saving technique, so it should be the first step to be done. And another method used in the emergency for control of PPH is the compression of the aorta. We can place our thumb over the above the umbilicus, that is, we have to compress the aorta. So this is the procedure of bimanual compression. One hand is placed over the externally over the fundus of the uterus, and the other intravaginal hand, it will be placed in the anterior fornix of the vagina, and we have to compress the bimanually, we have to compress the uterus. And then uterotonic therapy should be started. That is, as we already discussed, we have to give oxytocin 20 units, and this is the usually this is the first line of uh, medications we will give. It can be given either IV or IM, but intravenous route is the preferred route of administration, as it is an emergency condition. And coming to the complications of this oxytocin, it leads to water intoxication, nausea, and vomiting may be seen. If oxytocin, even with oxytocin infusion, if still there is a PPH, then we'll go with ergometrin, that is 0.2 mg, and it should be repeated every half an hour. Maximum of 4 doses should be given. And coming to the side effects of this ergometrin, it is hypertension, nausea, and vomiting. And this ergometrin, that is methergine, is our common name. This methergine, it is contraindicated in certain conditions, like if mother is having any heart disease, or if she's having hypertension or any vascular disease like migraine and TIA. In all such conditions, we have to prevent ergometrin. And next, if it is also, if even with ergometrin it is not controlled, then we'll go with the carbopros, that is PGF2 alpha analog. This is given in a dose of 250 micrograms, and every 15 minutes of maximum 8 doses can be given. And the most important thing, it should be contraindicated in asthmatic patients. And the next resort, it is a misoprostol. Generally, in if it is a primary healthcare center, or where there is no, if it is not, there is no availability of any drugs or any help, then the mainstay of drug will be the misoprostol, like in primary healthcare centers, etc. So it is a prostaglandin E1 analog, and it is used safe for both prophylaxis and for treatment with no significant contraindications. The dose will be the 600 to 1000 micrograms. It can be either given parenterally or sublingually. If it is given sublingually, then we'll reduce the dose to 400 micrograms. Fever and tachycardia can be seen with this misoprostol. And if uterine attenuation is suspected due to tocolytic treatment, that is like if we are giving any tocolytic agents, nifedipine or anything, then we have to give her 1 ampule of calcium gluconate in 10 ml. It is given intravenously. And then after this treatment, we have to inspect the genital tract for any traumatic conditions. If we are suspecting any lacerations, etc., we have to carefully examine, and then we have to suture them. And if still we are not able to control the PPH, then we'll go with the uterine tamponade or selective arterial embolization, and then finally surgical intervention can be done. So uterine tamponade, it is the intrauterine packing. We have to pack the uterus, and this is a safe and simple and effective method to control the PPH by providing tamponade to the bleeding uterine surface. And for packing, gauze is used, and the placement, it should how to place this packing means we have to start from the fundus and then progress downwards in a side to side fashion, and we have to avoid any dead space so that blood will not get accumulated. And this packing should not be more than 12 to 24 hours, and within after 24 hours we have to remove the packing and see for alternative therapy. And during this procedure, we have to monitor her vitals. So this is a image showing intrauterine packing. We are using a gauze piece, and we are packing the uterus from side to side, and there should not be any dead space. The other will be the other type of packing will be the battery tamponade balloon packing, and this is a silicone balloon and it is attached to the catheter, and this catheter is inserted into the uterus using either manually or ultrasound guidance, and this balloon it is infiltrated with saline water. Maximum of 500 ml can be infused into it, and then this will act like a tamponade and it will adhere to the endometrial surface, and it will prevent bleeding from the endometrial surface. And this is all about battery tamponade balloon. See, this is the image. So the catheter is inserted and the balloon is inflated with 500 ml of saline. The next uterine tamponades, the other method is we can also use a Foley's catheter. Uh, Infused with 30 ml, and the balloon should be inflated up to 30 ml. This is the catheter. The balloon it is inflated up to 30 ml. And the next is a selective arterial embolization. It is increasingly common therapeutic option for hemodynamically stable patients with PPH, and those who require fertility preservation. In all such conditions, we can go with the arterial embolization, and success rate will be almost 90 to 97%. Will go through the femoral artery and will embolize the uterine arteries. And the next will be the complications of this embolization. Some patients may develop post-embolization fever, and infection is the most common. Ischemic pain will be seen, and sometimes vascular perforation and tissue necrosis will also be seen at that area. And next is surgical intervention. The most possible surgical interventions we are going to do are the arterial ligation and then the uterine compression sutures and hysterectomy. Coming to the arterial ligation, the goal of arterial ligation is to decrease the uterine perfusion and subsequent bleeding. And with arterial ligation, the success rate will be almost 40 to 90% depending upon the artery which we are ligating. In uncontrolled atonic PPH, we have to perform a ligation of the uterine arteries, that is, ascending uterine arteries should be ligated, and or utero-ovarian arteries or infundibular pelvic ligament vessels or internal iliac arteries can be ligated in such conditions. And the next, after arterial ligation, the next surgical intervention can be uterine compression sutures. There are several techniques like Beeling sutures, Heyman sutures, and perineal transfer sutures or vertical sutures and multiple square sutures. To place a compression suture, the patient should lie in the dorsal lithotomy position and facilitate assessment of the vaginal bleeding. And then we have to take a large absorbable suture material. This should be this needle can be passed from anterior to the posterior surface of the uterus and we ligate it anteriorly. Depending upon the type of suture we are using, there will be different techniques. So this is the image showing Beeling sutures. See, we are taking the suture in the lower uterine segment first, and then we are going anteriorly over the fundus, and then from posterior surface we are coming into the anterior surface again. And this should be done first on the right side, next on the left side of the uterus, and then we'll tie it in the lower uterine segment. And so that the uterus will get compressed and it will lead to decrease in the PPH. This is all about PPH management. And the last final resort, even after Beeling sutures or any compression sutures, it is not done, then we'll go with a hysterectomy. So these are all questions you will be asked in PPH. First is define PPH and what are the types, and etiology of PPH. What are the causes of atonic PPH and risk factors? How do you manage atonic PPH? And active management of third stage of labor and surgical management. And the other will be the Beeling sutures. These are all questions in the PPH. And this PPH, atonic PPH management, it is, I think it is a 10 marks or essay question for you. Okay, if you're having any doubts, you can ask me. Okay, if you're not having any doubts, we'll close the topic. Shall I leave?
No doubts, ma'am.
Okay.